So what we thought that we would cover today, we're going to kind of do a tag team, is talk a little bit about what is SBIRT, and I know you've heard some of this in the earlier presentations, and kind of why think about doing the SBIRT. Spend a little bit of time on the history and the research that sort of supports it, and then some on the specific components that go into making up SBIRT, and then start to talk a little bit about sort of implementation and successes to date and things to think about if you're moving toward implementation or considering SBIRT in some ways, as well as some alternatives or ways that you might be able to facilitate using it in a variety of settings. So as we know, substance abuse costs the United States over $484 billion a year. And just to put that into comparison, diabetes costs about $131 billion and cancer $171 billion. So drug abuse is expensive. And I wasn't here this morning, but I'm sure that Tom McClellan did the pyramid to talk about the number of people that are would meet criteria for addiction but are actually not in treatment, and that the group that we actually see coming through the door of treatment programs is actually that small triangle at the very, very top, and that there's this much larger population that could benefit from services and hasn't had access to it. So SBIRT is screening, brief intervention, or brief treatment in some cases, and referral to treatment. I'm going to be showing you a lot of acronyms and mnemonics today. And the goals of doing SBIRT are to increase access to care for patients who are misusing or abusing substances. And it really is sort of ahead of its time in the sense that the new diagnostic criteria, DSM-5, have started to think about addiction and many mental disorders more along a continuum rather than a kind of categorical yes-no, and that's sort of been the premise for SBIRT all along. And then to improve linkages between healthcare services and substance abuse treatment services. So we'll talk a little bit also about kind of how these things apply if you are on the treatment piece to this equation. So SBIRT, the reason that SBIRT has become so popular is that there are a number of advantages to it. The first being that it doesn't require people that are trained in addiction treatment to deliver the intervention. As I said, it views alcohol and drug abuse as being along a continuum rather than a yes-no. And it offers a really different approach from what has been historically associated with substance abuse treatment for many years. So it's a very non-confrontational, with an effort to really reduce patient resistance. Because remember, we're talking largely about the group of people who are not in and of themselves treatment seekers at the time that you would be having contact with them. And that the responsibility for change really lies within the patient. SBIRT is actually both treatment and prevention. So again, if you think about addiction as being along this continuum, it can do everything from try to prevent substance use escalating, so prevent future negative consequences if the person continued to use alcohol or drugs or it became more severe. If they're starting to have problems, SBIRT can help to intervene earlier so that you can intervene before the problems become greater. And then for a lot of people, SBIRT is treatment. So the actual brief intervention will motivate a subgroup of people to actually think about making changes, and they do that without necessarily accessing what we sort of think of as formal substance abuse services. We're talking in part about SBIRT too because, as you've probably already heard this morning, it is being used in a host of places. Primary care, trauma centers, hospital emergency rooms, community health centers, and a variety of other places. So it really has become one of the most frequently used interventions. The other reason that we're talking about SBIRT is because historically it has been shown to work. So these are just some of the studies. You probably heard some of these earlier this morning as well. There have been meta-analyses, there have been systematic reviews looking at essentially the BI as the brief intervention piece to SBIRT that have shown positive outcomes. So brief intervention was often as effective as more extensive treatments. The BI studies targeting alcohol found it was that the people getting brief intervention were twice as likely to reduce their drinking at 6 and 12 months. They've reduced mortality rates in problem drinkers. They're associated with fewer accidents, fewer hospital visits, things that certainly are reducing the cost element that we've been talking about. And that one study showed that for every dollar that you spend providing SBIRT, you can save $6, more than $6 in the longer term in terms of less healthcare utilization. The caveat to that, as you've been hearing, however, is that can you go back on? Is that the majority of those studies and the research that is being reported here really has focused on alcohol. So historically, that's really where SBIRT got started. It was looking at intervening with hazardous and harmful drinking. A lot of the early studies were done in emergency departments at the time that people come in with alcohol-related accidents and issues. And so, if you flip to the next slide, it led to this large initiative to start to look at SBIRT and effectiveness treating other drugs. And there's been a lot, we're doing a randomized clinical trial in Richmond, Virginia right now of different intervention strategies with drug users. And the data are less clear. As you heard Richard Saves talking about, there have been a number of negative results. So the verdict really isn't in yet. There are several studies that are still in progress, and it'll be interesting to look at those kind of over time. So much of what really has led to the popularity of SBIRT has really come from the alcohol field. More recently, and part of why I think we're sitting here today, is that there's been additional impetus to implement SBIRT because the federal legislation now supports use of it through the Affordable Care Act. A lot of agencies are promoting it, and it's being, for example, mandated in trauma centers. It is supposed to be standard of care. The Joint Commission for Hospitals has approved it for alcohol, and Arlo will be talking more about some of the factors to consider with that implementation. But it really has generated a lot of enthusiasm for this intervention. So you might be wondering, certainly I was wondering when I first became familiar with SBIRT, so if it really is sort of this clinically effective with alcohol, at least, and it looks like it's saving money, then why isn't it happening in essentially every primary care clinic and emergency department across the country? So sort of what's the implementation sort of concern? And this slide probably summarizes a number of the things on the physician side to this. When physicians were surveyed and asked about the problem with doing screening for substance use in their patients and then moving on to a brief intervention if there were problems in referral, almost 60% of them said that they believed that the patients were lying. Time constraints was a big issue. They feared that by asking those questions, they would be questioning their patient's integrity. They were afraid that they might anger their patient. They weren't certain about treatments and what actually might work or not work. Or they weren't comfortable with the subject matter, or they were afraid the patient would go for care elsewhere and they would essentially be losing their clientele. And also insurance historically had not reimbursed for SBIRT. So a number of concerns that sort of made it really difficult, despite the early effectiveness data, to move this from research to practice. And some of those concerns are legitimate. There was a study that was done in 2003 that showed that if physicians actually did all the things that they were required to do through the U.S. Preventative Services Task Force, it would take 1,773 hours per year, or the equivalent of 7.4 hours per working day. And clearly, that's not going to happen, right? And so they're being bombarded with, you should be doing this, you should be doing that, etc. And it's really difficult to make decisions. And I think with that in mind, if you look at those previous barriers, that interacts with not feeling comfortable with the subject matter, not sure if treatment works, feeling like the patient's going to be angry, it really ends up in many settings making it not happen. Now, the interesting thing is if you go on to the flip side of that and you ask patients about how they feel about screening for alcohol, these were their responses. So the item, if my doctor asked me how much I drink, I would give an honest answer. 92% agreed or strongly agreed. If my drinking is affecting my health, my doctor should advise me to cut down. 96%, virtually everybody. As part of my medical care, my doctor should feel free to ask me how much alcohol I drink. Again, vast majority agreed or strongly agreed. I would be annoyed if my doctor asked me how much alcohol I drink. 86% disagreed or strongly disagreed. And I would be embarrassed if my doctor asked me. Again, a very high percentage disagreed with it. So you know, these are self-reports, and you can't necessarily generalize them, you know, apart from people that are in the study. But clearly, there is a disconnect between what the physicians and the medical providers are perceiving and what the patients are reporting about their views on what happens in that medical visit. So there's this disconnect, and it has led to a lot more attention being directed not just at SBIRT, but at a host of interventions and looking at ways that we can better expedite moving things from a research setting into actual practice, because ultimately that's really where the findings should be going. Any questions about that? Okay. Everybody had their sugar and caffeine. All right, so we're going to go through briefly the components of SBIRT, just to make sure that everybody's kind of on the same page. So again, it stands for screening, brief intervention, referral for treatment. First piece to that is screening, rapid, proactively identifying people who may or may not be at risk for alcohol or drug problems. Intervention is focusing on increasing the person's awareness of their substance use and working on their motivation to make a change. And then ultimately, for those who need it, it's referring them to treatment services. So let's go through those really quickly. So screening, the core principle of SBIRT is you want to screen everybody. Okay? So SBIRT is not something that's typically done when people walk through the door of a treatment program, because they're always sort of self-identified as coming with a problem. SBIRT is really about looking at settings in which there's going to be a subset of people with substance use problems, but you want to essentially be asking everybody the question. And the good news, I think, is that there's really not a single right way to screen. There are just things that you need to be cognizant of. It needs to be brief. It needs to be something that's valid and reliable. And that it needs to really focus on all substances, and that would include alcohol and tobacco as well as other drugs. So kind of like your GPS, you have multiple options when you're thinking about screening. You can take the shortest route and ask the fewest questions. You can do the fastest one that takes the least amount of time. Or, you know, if you have the time and you're interested, you can take the scenic route and be spending a little bit more time on that component. In a lot of settings, because again, remember, we're going back to time is critical within this, right, on the physician side, so or other practitioners, so you really want to determine who you need to be asking these questions of. And so in a lot of settings, people will start with a pre-screen, some really general questions that let you know who you should go on to talk to. So for alcohol, historically, those have been, in the past year, some of them will ask, did you drink beer, wine, or liquor? Others will ask, how often did you drink beer, wine, or liquor? We'll talk about that in a second, too. And then how often did you have, and for men, it's 5 or more drinks in a day. For women, it's 4 or more drinks in a day. Those questions, with those questions, nearly 3/4 of US adults would never exceed those limits of that pre-screen to then go on to ask them subsequent screener questions about problems. And remember, when you're asking about drinking, one person's standard drink might be a little bit different from somebody else's, and so it really is important to specify. I'm not going to belabor this, but same thing, similar questions to do a general screen about drugs, be that illicit or and or misusing prescription drugs. So you can do the same thing to figure out who you want to go on to ask more questions of. So briefly, there are a host of screeners that can be used, and it really is sort of figuring out what's going to work best in the particular setting with the people that are employed there and the patients that are being seen. And these are some of the more typical ones: the CAGE, the audit for audit C, and the assist.
Are they all in the public domain?
Yes. And that's an important issue. Good point. That can often make a difference. So the CAGE has been around for a very long time. 4 questions, again, it's the mnemonic. So have you ever felt you should cut down on your drug use? Have people annoyed you by criticizing your, and this says drinking or drug use, so there's an alcohol CAGE and there's an other drugs CAGE, essentially. Have you ever felt bad or guilty about your drinking? And have you ever had an eye opener first thing in the morning to steady your nerves or to get rid of a hangover? Frequently used, it is reliable, it is valid. Typically a score of 1 or more for women would suggest they're screen positive and you want to go on to ask more questions. For men in many settings, that's 2 or above. But even those can be modified depending upon the participants that you're seeing in patients. So how many of you are familiar with the audit, the primary eyes? So that's been around for a long time from the World Health Organization. More recently, that has been condensed to an even briefer screen called the Audit C, which is just 3 questions. How often do you have a drink containing alcohol? And those are the response options the person can check. How many standard drinks containing alcohol do you have on a typical day? Is it the one? Yeah. Oh, it was supposed to. Sorry. These are probably still not the final slides. So it was supposed to tell you the standard drinks, but essentially it's a 12-ounce beer, 5 ounces of wine, or a shot of liquor. And then you sum the answers to those 3 questions, and again, it gives you scores at which you would want to go on to ask additional things versus not. And then the assist, which has been, is used a lot in research settings, particularly more recently. That was developed by the World Health Organization, and that really does look at all the substances you see listed in the part column. And not only does it look at all of those substances, but then it also is scored to tell you kind of what level of next step you would take with a person, ranging from no intervention to a brief intervention, which we'll talk about in a second, to more formal treatment. There are also screens for special populations. There are screens like the CRAFT that can be used for adolescents and tend to work better with pregnant women. The TACE and the TWEAK are variants on the CAGE that you saw earlier, but they add some additional questions that focus on things like tolerance. And again, have been shown to be quite reliable and valid and work well if you're focused on a specialty population. And if anybody wants copies of any of these other things, I'm happy to talk with you afterwards about that. All right, so if the person, you're screening everybody, some folks will screen out on a pre-screen already, some will go on to the screening, and then based on that, if they screen positive, you're going to move on to a brief intervention. And again, this is about increasing a person's awareness about their substance use and helping them look at potentially making some changes. Brief interventions are defined as something that lasts between 5 and 15 minutes in general, where often information or advice is offered. Again, it's focused on trying to increase motivation to change using motivational interviewing. How many people are familiar with motivational interviewing? Fast, we'll zip through those slides. Okay. And then we'll teach potentially behavior change skills to, again, reduce their use and to potentially reduce the negative consequences. SAMHSA has defined a brief intervention as anywhere between 1 and 5 sessions, up to a total of 5 to 60 minutes. And in the SAMHSA research with SBIRT, they've identified that approximately 15% of those screened go on to need a brief intervention, and another 3% would go on to a more intensive brief treatment. So again, why brief interventions? Because they've been shown to trigger change. Because a number of the early studies, again, primarily with alcohol, have shown that just 1 or 2 sessions of a brief intervention can produce more change than no counseling at all. And that they can have outcomes that are similar to more intensive, longer treatments. So essentially, a little counseling can go a long way. Elements of brief intervention, again, another mnemonic, it's frames. So when you read about or hear brief intervention, it can mean a variety of different things. These are just some of the components that are typically associated with a brief intervention. Giving the person feedback about their drinking or drug use, often based on some of the questions that were already asked. Responsibility, recognizing that it's the person's decision about whether they're going to make a change. Offering advice, often asking permission to, but then offering advice. Offering a menu of options. If they want to make a change, it's really about not saying do this, it's about giving them multiple options and seeing what they think might be useful. Empathy, really being caring and concerned about them. And self-efficacy, so you can get them motivated, you can get them ready to make a change, but if they don't think they can do it, the rest of that is really often all for naught. So since most everybody here is familiar, I'll go through this really quickly, but most brief interventions have at their core, in terms of how they're delivered, motivational interviewing, which was developed by William Miller, is client-centered, yet directed, and really works on that intrinsic motivation to help someone look at the fact that they're feeling ambivalent in most situations about change, and exploring the good and bad things about making a change. Motivational interviewing and Bill Miller's work in this really came from the fact that there was a lot of research coming out showing that a more confrontational counseling style, that those things were generally less effective than using this particular approach. And really, the biggest thing was, I think, the recognition that ambivalence is normal. Think about something that you might be changing yourself, going on a diet, deciding to start an exercise program, quitting smoking. If those things were easy and there wasn't ambivalence, we all would have changed those things in ourselves. So it's really about recognizing that a person coming in with alcohol or drug problems is looking at the fact that there are good things about continuing to use, and there are some not so good things about that, and things that they might benefit if they do make a change. So motivational interviewing looks at trying to counteract that ambivalence and move them in the direction of change and away from the status quo. Those are the 4 principles, and we won't spend a lot of time on that. And then these are essentially the ORs, the things that are part of the toolbox of what individuals that are doing motivational interviewing, either in a brief intervention or other contexts. So open-ended questions. We flip one just to see if yeah, okay, so open-ended questions. So open-ended questions are not yes, no. When I do training with physicians, often just trying to work on that as being a change in their behavior is an important. It's really easy to go through the checklist and just be, have you done this, have you done that, etc. So doing things that are going to require the person to start talking. Encouraging them to explore their issues, looking at understanding their point of view. It lets the client, the patient, have more control over the conversation, and it gives you, the person doing it, a lot more information about them and other issues. Affirmations, so you want to be validating the person's feelings. This could be compliments, this could be statements of appreciation about, that's a great suggestion, thank you, it must have been difficult for you to share that with me, etc. Reflective listening is really at the core of motivational interviewing, so this is really about being a good listener and really hearing what the person not only says, but what they actually mean by what they're saying. So creating an environment where they feel that it's okay to say anything, be it that they don't want to stop, that they might want to make a change, etc., and being accepting of that, not judging, not criticizing, not blaming. So reflections are things that you do with things like, so after the person has told you something, it's so you feel such and such, or it sounds like you, or you're wondering if essentially you are reflecting back what they said, to changing some of the wording to see if you've heard them correctly, and you'll be amazed at how much that gets them to continue talking. The most important thing to recognize with this, though, and again, I think in the medical community, this can be sort of difficult, is that when you're reflecting, your voice has to go down. You're making a statement to them. So you don't want to be going, so you feel like you shouldn't do that? That's not a reflection, and then that can very easily feel judgmental or accusing. So it's really about learning to say the reflection as a statement. And it's really keeping, I'll talk about this more in just a second, it's about recognizing that direct persuasion, you're trying to tell them what to do, can be counterproductive. So it's really about coming to recognize that you want them to say the words and you want them to be advocating for change. And then summarizing. For people at my age, this is essential, or else I forget what they've told me. But for others, it also gives you a chance to reinforce certain things that the person has said, so that they might again be thinking more about moving in the direction of change, and it helps them to also recognize that you've been listening to them. So within the context of SBIRT, lots of different clinical and research groups have developed different ways of providing the brief intervention. As I said, if you're reading any of the research literature and you hear brief intervention, it can mean a host of things. One of the interventions that has been used most frequently is the brief negotiated interview, which actually came out of work in the emergency department with alcohol. A brief negotiated interview is about 5 to 7 minutes, and it gives the person feedback and advice. It's very client-centered, motivational interviewing, and you base what you say based on their level of motivation or readiness to change. So these are the 4 components. The practitioner would raise the subject. Essentially, if it's okay with you, let's take a minute to talk about X. You then provide feedback. As your doctor, I can tell you that drinking or drug use at this level can be harmful to your health and may play a role in the health problem you came in for. Enhanced motivation. Often they'll use a readiness scale and do on a scale from 1 to 10, how ready are you to cut back on your use? And then negotiate a plan. How would your drinking or drug use have an impact on your life in order for you to start thinking about cutting back? So I think rather than talking about this, it would be helpful just to give you an example. So we're going to really quickly show you 2 videos one is of how not to do it first. With emphasis on the not, okay? And then with that same patient, we'll show you an example of a brief negotiated interview. Comments? Thoughts about that?
Can't help but think that if the doctor wasn't multitasking, he'd be bored to death.
I'm amazed that the doctor can actually, like talk and do that at the same time. It's kind of like turning on and walking for me. It's not as complicated as it gets. Other thoughts? Also, note that second one, that took was between 3 and 4 minutes. So it really is, I think sometimes it feels longer than it is. I mean, that is actually, that happened in a pretty short period of time that he got through the list of things. Okay, then the last piece, which is actually kind of where a number of people in this room come in, is the referral to treatment. So for those individuals in particular, anyone who would meet diagnostic criteria for a disorder or is really having significant problems with their addiction might require more extensive care and access to specialty care. And as I said, this is where the substance abuse counselors come into it. And it really, I can't stress this enough, it really needs to be a coordinated system. Because I think when it's not a coordinated system, on the practitioner side, you play into the, well, why bother? Because I'm not going to be able to get them into treatment anyway, or that, they'll never be able to, for that to be successful. So it really needs establishing linkages and coordination between the specialty care and the medical and social service providers. And again, SBI in of itself for alcohol has shown beneficial effects, even without the referral to treatment. But those things really are important, again, particularly for those with more severe disorders. And that handoff, the going from primary care to specialty treatment is really, really important. There have been some studies that have actually shown literally, walking them physically from where they were at the hospital to a treatment program can be very, very effective. And the research has shown that essentially an MI-based brief intervention can increase the person's participation and retention in substance abuse treatment. So it's sort of twofold. It's not that they're just making the referral to treatment, it's that they're having that brief intervention conversation with the person, which is hopefully making them more motivated to make that change, and then trying to really act on that as expeditiously as possible to actually get them into treatment. Questions about any of that? Yes.
Well, when you were talking about it, I envisioned like having like a questionnaire and implementing it that way. So would you say that having more of a conversation like the doctor did would be better than?
Again, it really depends upon the setting, so there's not like a right way or a wrong way. I think there have been a number of studies that would suggest the personal contact can be good, but you have to sort of weigh that by who the people are that are going to be asking those questions and the way in which they're going to be asked. That's actually a great lead into the next thing that I'm going to talk about. Any other questions though before we go on? All right, so before I turn things over to Marlo, I just wanted to say one more thing. And the point I'm going to get to is thinking about, in this day and age, how we might be able to use technology to facilitate some of these things, okay? So, and I want to talk about this a little bit in the context of kind of how I came to really particularly value strategies that integrate smartphones, computer tablets, some of that technology in doing some of the pieces of SBIRT. So very briefly, I spent too many years for me to count, a lot of years working on the side of really working with practitioners about training in addictions. At one point in time, there was a really intensive effort to provide addiction training to physicians from a variety of medical practices, where they were meeting with our group regularly. We were doing role plays. We were going through the whole process and really trying to intensively change the way that they viewed addiction and the extent to which they would then be following some of the new skills that they had up with their practice. And at the end of this, we actually had the chance to do a study where we went into one of the clinics that had several of the practitioners that had participated in all of this. And we told, this was an OBGYN clinic, and we told them in advance that we were going to be camping out for 2 weeks, surveying the patients in the lobby area before the waiting room, before they went to see the person, and that we were going to be looking at the charts to see what happened in the medical visit, to kind of compare those things, okay? So with that knowledge, recognizing they had just graduated from this training program, what we found was really nothing had changed. Like, they identified, when we have like 2% of the cases that we found in the lobby area, sort of. And it was really very eye-opening for me, because I think it spoke to all the things that we talked about earlier, the barriers, the time constraints, et cetera, even with really fairly intensive, a really intensive program about this. And so that led me, because I was doing a fair amount of less intensive training, to sort of refocus my goals. And so I really did get to, in many cases, if I only had, a couple of hours with practitioners, just trying to get them to think about asking the questions of a patient, as in, how many times did you drink, use marijuana, et cetera, versus the simple did you. Because again, did you is a yes, no, it's a closed question, and it makes it really easy to say no. If you say how many times, the implicit assumption is everybody's using, and it's okay to tell you that they are using. Okay. And in particular, I tried to get away from the, you didn't use drugs, did you? Because that really does. We were doing a study of caffeine use in pregnancy with a suburban practitioner here in Baltimore, who shall remain nameless. And we trained the person in talking about caffeine, et cetera, and about 6 months after the study was over, I brought someone to see him, a younger person, and there was a language issue, so I sat in while he was going through the screener, and with me in the room, he did that, well, you don't use drugs, do you? And checked off the boxes. So these are really things that need, attention and kind of tailoring. And then my aha moment that sort of led to the technology piece was I did a 2-day motivational interviewing training program with a group of nurses, and their focus was on pregnant adolescents who were smoking. And they came in with an incredible amount of enthusiasm. They had read some about motivational interviewing. They really wanted to learn this. And we started to go through the training, and when we broke into the first role play, and the second role play, and the fifth role play, it became really clear, despite lots and lots of efforts to do that, it went really contrary to everything that they'd been trained prior to that. And so there was just this incredible need, is what they described, because we had a discussion about it, to tell the person all the things that are bad about smoking. and even, with the data to suggest that that's not going to help, and in many ways, that could be harmful, really just could not sort of get past it. So I went through a period of despondency and heavy drinking, and luckily, Steve Andersbach from Wayne State came to see me and wanted me to serve as a mentor on his first NIDA K Award, and he was really committed to looking at how technology might be able to facilitate things such as substance abuse screening and brief intervention. And the message that came with that was, think about, he really came at it from a public health perspective. Think of the reach. Like, even if you're only having an impact on 5% of people, if you could actually be doing that really literally across the country, think about what that impact would be. Getting a 5% reduction in smoking, for example, is huge on the public health side. It's going to be consistent. You know that if you're actually doing something with the tablet, it's going to do it the same way every single time. It's flexible. You can modify it. You can make it fit your clinic in different ways. It's anonymous. We were just talking about this before the break of, there are studies that show that there's a difference in talking to the screen and answering questions sometimes than talking to a live person, which gets back to the question. It's really, there are pros and cons to doing things in this way or with a questionnaire versus in person. And it's economical. Once you've got it and it's programmed and you can be using it, the costs become much less than the training efforts and the things that go with it. So Steve developed, this is Petey the parrot. If you want to hear what he sounds like, find a video of Stephen Hawking, because literally, Petey speaks with Stephen Hawking's voice. At the end of this information, I can tell you a story about that. But essentially, Steve developed this interactive software where the person puts headphones on, and it can do screening. It will ask the questions, and they can have them read so they can hear them, so literacy is not an issue. And it will walk them through it. And PD like flies onto the screen and he interacts with them, and he, a little light bulb can go on over his head, he can give them feedback and education, so he essentially can deliver a brief intervention. And this is an example of just what a screenshot would look like. So this is drug use, is it worth it? Right now for you, what would you say is the single biggest reason you use drugs? And again, they can go through and have the person, have PD read each one of those to them, or they can read it themselves. And it then takes those responses and then lets PD sort of filter it back. And we've done a series of studies with this to demonstrate that this works from a research perspective as well as a live person delivering it, okay? So am I sitting here trying to tell you that PD is as good as a well-trained practitioner delivering SBI? No, I'm not. But is PD better than what might be happening with the number of the practitioners that I and other people have trained, where you do the training and then you're gone, and they're really left to their own devices? In a number of settings, yes, because at least you know that what you programmed is going to be delivering. And I think, ultimately, on my perspective, I'd like to see them kind of interact with each other. Because what's happened, I think, historically now it's become an either or. The study we're doing right now is comparing kind of one against the other. I would love to see it where the technology can help to inform the practitioners and that you can actually do it sort of as a joint venture. Any questions about that? If not, then I'm going to pass the time to Marla and Daphne.
Thanks. Well, I am going to talk to you about actually some of the steps to actually implement SBIRT into practice. So we've heard a lot this morning and just now about the concepts and what it's like and the research studies. And I've had a lot of experience in Maryland and particularly in Baltimore working with practitioners across a number of health settings, community health centers, hospitals, schools, nursing homes, to actually implement this into practice. And one of the first things that I want to say is that when I started doing this work, because I got into this without a huge research grant and with a very small foundation grant, we had to sort of say, okay, we don't have a lot of money, and when looking at a lot of the prior implementation work that had been done, what we found was that a lot of the dollars had been used to hire a lot of extra staff, health education staff that were adjunct to the primary care practice, and when grant funding ended, as everybody knows, usually the practice ends and it's not sustainable. So what we said was, we don't have a lot of money, we don't have any money to offer practices, so we need to go in with the goodwill, the commitment of practices, and we got to figure out how do we truly integrate this into what these practices are doing so that it ultimately becomes a part of what they do and is sustainable. So we went into it really with that objective. And so the steps that we now have used in all the settings that we've implemented it have been really successful in getting this fully integrated as a routine part of care, and it's still happening in the settings that we have started in. And the first thing that is really important is building readiness. So you can't go everywhere and do this. I mean, SBIRT, as wonderful as an idea as it is, isn't going to be palatable for every organization in every setting. And so as much as some of us, may want to see SBIRT happening, if you approach an organization and they're like, hell no, and you continue to have conversations and they still are like, hell no, it's probably not going to work. So there's really an important step around assessing the readiness of an organization, building the readiness if you get some little bites that maybe they're interested, but you really do have to have a culture interested and somewhat supportive of doing this. And really at the heart of this is you have to have leadership support. And we've heard a lot about, we can train doctors all we want, but at the end of the day, we can train them and it doesn't assume that things are happening. And that's more the case, as we know now more than ever, with healthcare doctors being much more employed by organizations. We have less private practitioners, and so they really are kind of working for organizations. And so what the organization decides is what's going to happen is what's driving a lot of the practice changes. And so getting that leadership buy-in and commitment at the highest levels is critically important. And that usually requires making a business case, and we heard that this morning. So, you know, getting that sense of why this is important, and we have the ammunition now more than ever with the Affordable Care Act and all of the different fiscal drivers that are embedded in that to make that case. So, you know, that first sort of step of assessing whether or not your setting is really the right place to start is really important. And these are just some of the different ways that, you know, in terms of culture, that you can sort of have conversations with the organization and their team around figuring out whether or not you have any shot of being able to convince them, or maybe they can convince, you know, they're already sold because they know this is a pervasive problem. They recognize that they're struggling with patients. They're seeing these patients every day. I don't know what to do. My ED's filled with them. I got to reduce my hospital readmissions. I know that it's the primary reason is drugs and alcohol. So, you know, there's a lot of different ways, but you know, there needs to be some level of understanding around the issue of addiction and its role in the setting. And as I talked about, having leadership buy-in is really critical. And when I say leadership buy-in, you know, I mean this both at the administrative level, but also at the medical level. So when we did this, we did start with the CEOs of the organization, because at the big strategic level, you know, they're the folks that really need to say, okay, this fits in with my overall goals. You know, I'm all for patient-centered medical homes. I'm on the hook now for getting diabetic outcomes, glycemic control. I'm on the hook now for getting hypertension under control. I run a health center in the middle of inner city Baltimore. A lot of my patients are struggling with drugs and alcohol, and I know if they're shooting heroin every day, they're not following that diabetic treatment plan. So if I'm going to get glycemic control, I better do something about the drugs and alcohol. But what do I do? And so there's sort of that level of leadership buy-in. But having that medical champion, that medical director, is equally important, because we got to bring those clinicians on board when we get down to really doing this. So it's really at both levels that we need to get that leadership buy-in. And we talked about making the business case. And this morning we heard about some of the different regulatory agencies. I think what's her name, Connie? The woman from Kaiser talked about, or Rich talked about, the different Joint Commission requirements that are now required for hospitals to do alcohol screening, the emergency departments and trauma centers. But more and more, we're seeing patient-centered medical homes, NCQA, for accreditation. There's outcomes that include looking at drug and alcohol screening. We're seeing it in accountable care organizations. So increasingly, we're seeing not necessarily pure regulatory drivers, but we're seeing system-level delivery system changes that are really forcing systems to pay much more attention to the implications of drugs and alcohol on the broader outcomes that these systems are trying to achieve and need to achieve now. I mean, really need to achieve for ultimate fiscal success and success for patient health outcomes. So what are the steps to, once you get that buy-in and you got an organization who really is interested in doing it, what are the steps to do this? And a lot of times we think, you know, we can just go in and train the docs. You know, okay, we want to do it, let's talk to the medical director, let's set up some training and walk out the door and assume that that happens. And we know that that's not the case, right? So what we have found is that there really is a process for figuring this out. And this morning, again, you heard a lot around workflow, workflow, workflow. And that really is kind of at the heart of the approach that we've taken. We kind of have assumed that, you know, your federally qualified health center here looks different than this federally qualified health center over here. They all don't operate in the same way. They all might see a little bit of a different mix of patients. Their operating procedures are different. Their workflow, their staffing configuration is different. And as a result, we have to be flexible in being able to infuse and integrate the SBIRT into what's going to work for that organization. So we really have to figure out how do we design a process that's going to really customize SBIRT into that organization. And the best way that we found to do it is to go through these steps. And I'm going to talk about each one. So the first one is assemble a planning team. So what we found is that SBIRT really isn't about just one or two folks in the organization that have to be involved in doing it. It really touches a lot of different aspects if it's going to be successful. And if ultimately we're going to get buy-in, it's like any project you introduce in an organization, people like to feel involved, right, in designing it right from the beginning. They don't want to be told, okay, here it is, go do it, and feel like they didn't have a part of it. So what we did was we created multidisciplinary teams of all of the key folks that in the particular organizations we were working with would have some role in the SBIRT process. And we formed those teams as the planning team to really help us design and then follow through and implement the SBIRT process. And the usual, the usual folks were obviously the medical folks. We have the practice management folks, which would include the folks that supervise the medical assistants, the nursing staff. We had the behavioral health folks, if they had a behavioral health department within the organization, social work, case management. The front office was really important, so the front desk person, the staff that managed those people. And then we also had the IT people, because a big piece of this, as we heard, is really that decision support and that ability for us to get this into those electronic health records and finance, because we want to be able to get paid for this. We want to be able to bill for it. So we really put all those folks together to help us design this. And they really worked with us from start to finish when we talk about those steps. And so, workflow, 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 the first thing that we did was analyze the workflow. And we used sort of a classic CQI, NIATEX process where we conducted walkthroughs of the setting. So we, were little investigative reporters, and we said, okay, just be prepared. We're gonna, spend a couple hours with you, and we're gonna ask you very detailed questions about how this works from the time a patient comes into your clinic door to the time a patient leaves, and we want to understand every single step along the way about how it works and experience that from the patient's perspective. And so we spent the time in every setting, even in the ED settings, in school settings, doing this to be able to understand how that operation worked. And then we produced flow charts, and we laid out those flow charts, and we said, well, did we get it right? And we fixed it if we got it wrong, and inevitably we didn't get it perfect. And we really tried to understand how the operation, the workflow of that clinic worked before we then layered on SBIRT. And based on that, we then presented a couple different options for folks to consider around how, based on their operation, they thought SBIRT would work best. And there are a couple different models that we've talked about already this morning that are out there. One is pre-screen with current resources. And the underlying thing here is pre-screen, because you don't always have to pre-screen. because then you have pre-screen and screen, so that's a two-step process. And that's what we kind of emphasize when we think about this with clinics, because of course they're telling you, I don't have time, we got to figure out how do we integrate this with the 100 other things that the U.S. Preventive Health Service is telling us to do. But one model is you can pre-screen all patients, then go on and screen those with positive responses. The primary provider would deliver, whoever you assign to deliver the brief interventions, and then you can refer to treatment either on-site or off-site depending on what your organization has. Another model is that you just screen. So it's the same model that we just talked about, you just don't pre-screen. You just move right into screening all patients and delivering the brief intervention using existing resources with the primary care provider, and then you make a referral to treatment. And then sort of hybrids of these two are that you can add support staff. So as we talked about, in some cases, especially with Connie, the primary care provider really wants to be involved in the delivery of some piece of the action here after there's a screening result. And we found that to be true as well, that the primary care provider, whether they delivered the full brief intervention or they just introduced it and delivered brief advice, but one of the things, especially with patient-centered medical homes, that we're finding is really helpful is that adding the use of these other team members that we now have access to in the primary care clinic, like nurse case managers, health educators, social work case managers, who can be brought in to reinforce and do more of the brief intervention after the provider introduces it, and then do the referral to treatment. So that's sort of another kind of hybrid model. And again, this is going to depend on your clinic and whether that clinic has those resources. And then the fourth model is that integrated model that we talked about a lot this morning, where you screen or pre-screen, you have the primary provider doing some level possibly of discussion with the patient, but it's really that behavioral health specialist who's in the clinic that really is the focus for the delivery of the brief intervention, and then we would, if appropriate, refer the patient to treatment. So, figuring out which of those models is the one that you think works best, again, is really around what fits with the workflow. And so that's why having that workflow is going to be kind of the really important foundation for figuring out how it's going to work best in that particular clinic. Another important, decision point to think about with clinics as you're implementing this is who are you going to screen and deliver this intervention. And we heard this morning that it was on annual visits. So at Kaiser, they were delivering the screening and brief interventions initially on kids for all their well child visits, and it sounded like for the adults as well on their annual physical exams. So that's one way to do it. You could do it twice a year. You could do it universally on every visit. If a patient comes in, you just universally screen them regardless. So figuring out for which population and the frequency is going to be really important when you start building that protocol. I will tell you that in the majority of the clinics, I would say all of the clinics that we work with, the decision was made to screen at every visit. And the reason that we ended up deciding that, even when we started, as Connie talked about, with screening more annually, was that when we found that we made the mistake and we asked them again when we really shouldn't have, they changed their answers, even though it was maybe only 6 weeks later. And one of the reasons was that the more we asked, the more normal it became for people to hear the questions, and it wasn't like, why are they asking me these questions now? So the more we continue to ask, it's like when you and I go to our doctor and they ask us all about our sexual health, and we have to circle the happy faces. The first time you're asked that, you're like, why is my doctor asking me that? Now you go, you're like, okay, I gotta fill it out, right? You answer the questions. So the more we ask, the more normal it becomes for our patients to expect to be asked, and hopefully the more honest they will be in answering the questions. And then, of course, as Dossie talked about, we have to pick the screening tool. And as she presented to you, there's a range of different options out there around screening instruments. And again, that's where understanding your patient population, understanding the time constraints that you have, who's going to deliver the screening, under which model, and the time they have, and their capacity and their training is going to be really important. For most of our clinics, what we've ended up doing is the Audit C, because it gives a score. It's short, it's sweet, and it gives a score, so it's helpful then to guide the clinicians on the drinking side what to do around that score with the brief intervention. And then we just ask 2 drug questions around illicit drug use, and then we pulled out the prescription drug question because it's such a big issue in the city. And of course we ask about smoking. But picking that is important. Documentation needs. So, we started because we were piloting on paper in a lot of these clinics, and we collected the data to see what our screening rates were, and we quickly realized that there was no way it was going to last on paper, and that we had to spend the time getting it into the electronic health records. And so, as the world, as we know, is shifting, and it's no more, well, do they have one? It's pretty much everybody's either got one or getting one. Figuring out how to get that process and those instruments, the screening instrument, the BI documentation, the documentation of the referral to treatment actually into and integrated within the health record so it's easy and flows with the process that you outline is really, really, I can't emphasize how critically important that is. And again, a lot of times we think it's enough just to put the screening in the electronic health record with the results and let the provider assume that the provider in their free text little SOAP note, progress note, is going to document. We found that that wasn't happening. And so we went to our providers, oh yeah, I'm doing it. I'm like, well, you know how it goes. If it's not documented, it's not happening, right? So we actually, in all of our settings have developed BI documentation flowcharts that are simple and easy and allow the physician to just click and document the brief interventions that they are doing. And then they get credit for it. They can follow up and see what's done. Another provider who comes back and sees their patient can see what was done, and it just makes good sense. And this is just, I know it's difficult to see, but you can see it's a screenshot of the 3 audit questions with the score in an electronic health record, and the brief intervention, those boxes: counsel to continue abstinence, counsel to continue healthy use of alcohol, patient engages in moderate risk alcohol, counsel to reduce use, patient engages in high risk alcohol, referred for specialty assessment, patient declines services, other comments, and then we have a similar one, checklist for the drug use. And so, again, it's, just boxes, and you can customize this for, your particular system based on your providers, and we customize this. So, that might cost a little more because most of the electronic health record systems that we've worked with don't have any standardized validated screening instruments in their systems. If they have any, it's usually the cage. And so we have had to make adaptations and customizations to the EHRs that we've worked with. In terms of the brief intervention, we talked about the different options that are out there, or combinations of options, and they all are good options. There's, I don't think, any right or wrong answer. The research shows good results with using, the range of this. I don't think we've got good research out there, as we talked about this morning, around patient-centered medical homes and how do we really embed this and use that team model effectively in the delivery of SBIRT services. So I think, I think the horizon is really still very fresh in terms of what SBIRT will look like as healthcare and this new team model of care is really evolving. And we need to evolve with it as we think about how healthcare, the delivery of healthcare is changing in these settings. There's a lot of discussion around, well, are they really doing brief advice? Are they doing brief intervention? Rich talks about, well, you really need to have good efficacy around a brief intervention. The reality is the providers really only do have so much time. And if you go in and tell them, it has to be 5 minutes, it has to be this, they're not going to do it at all. And so what we have found, and again, Connie talked about this too, is rather than focus on, it has to be 3 minutes, has to be 5 minutes, and it's this separate big brief intervention, is that it's not a separate anything. It's really around how do we have this conversation integrated as part of your encounter and your conversation. And how do you look at that screening result as almost like the fifth vital sign? So we really train our providers to look at that screening data when they look at all of the initial triage data, the initial patient assessment data before the patient gets in the room, the vital signs, their weight, all that stuff, and their screening result. And we use that to then begin to counsel the patient about their diabetes, their hypertension, because we know, as we talked about, that the drug and alcohol use is connected to that. We can't separate the conversation, as we saw in the video that Dossie showed. It really is very much connected to their medical care, and it's going to make more sense to the patient if we connect it to their medical care. And when you do that, it really isn't like, okay, I've got my 15 minutes, I did my 15 minutes, oh my God, I got to look at that screening result, now I got to do this BI in 1 minute. It's really about just incorporating it into your whole encounter. And that feels much better when you talk to providers about that, and it makes better sense to them when you talk about it, and it doesn't it will take more time, we don't lie. It is going to maybe take a little bit more time, but it's not going to take a whole lot more time, and it's going to be worth it. So the referral to treatment considerations, again, this is where you guys can really come in. It's wonderful when we have the integrated model and we have on-site behavioral health services and substance abuse treatment services right there, and we can do a warm handoff and we can actually walk the patient over to the substance abuse treatment program, and we set up a system, which we've done, where we have that, where the intake specialist will greet the patient, meet them, make the appointment right then and there, and the patient leaves with an appointment for that assessment. That's wonderful, but we know that's not going to happen everywhere. And so figuring out how we have more than just give the patient the referral and leave and let them and hope that they actually are going to follow through and do it is not good either. So it's helpful to think about how do we at least help patients make those appointments and help them make those connections before they leave the clinic with them and for them. And so that's, as close as a warm handoff you can get if you don't have the treatment program on site. And the other big piece, which is where you guys can come in, is really having those relationships. A lot of times, as you know, we have such fragmentation between our substance abuse treatment providers and our medical care system. And, oh, I know Dr. Saluja over there, but have you ever met him? Have you ever talked to them? You probably share 30 patients together, but there may not be a real relationship. So as part of the process in setting this up, one of the things that we've done is really foster those relationships. Before we go live, we figure out who are the set of providers that are most likely to be the referral sources for this clinic, and let's have a meet and greet. Let's bring those directors, those intake coordinators to the clinic, let the provider, primary care clinic go to the actual treatment program, get to know the process, put faces to names, so that when you call and you speak to Miss Miller at the treatment program, she knows who you are, you know who she is, and it just, you know, allows, as we know, for a much smoother and better and more effective handoff to treatment. So those are things that you guys, you know, certainly the medical community needs to do a much better job, but you guys can be really helpful and supportive too in sort of strengthening those relationships. And then, of course, training is important. Once we do all those other good system things, we do have to spend quality time training and retraining, doing booster trainings with all of the staff. So again, you know, we've spent so much time focusing on let's train the docs, let's train the docs, let's train the docs. And I'm a nurse, so, you know, I always say, well, hell, aren't we training the nurse practitioners? And what about the nurses? And what about the MAs? They're the ones who the patients are really talking to, right? So we train everybody, front desk staff, anybody and everybody, you know, needs to have this knowledge. And, you know, given different roles, we may separate training because the training may need to be more focused on screening if the MAs are doing that, more focused on MI if the providers are doing that. So, but training is really important. And then this, I don't want to de-emphasize, I want to really put a big underline around continuous quality improvement. When you implement this, it's not enough to just let it go live and assume it's going to happen. It's really important to then use good data to then monitor whether the practice has been really adopted. And so figuring out, you know, at a minimum, getting screening rates and being able to see whether or not BIs are appropriately being done, as well as referrals to treatment. You know, getting that data right away when you first train folks, within the first 2 months, going back, feeding back that data, modifying your protocol based on what you see, actually retraining. I mean, we've done things where we've had really low screening rates, actually go in and observe the process, see how the questions are being asked, you know, really do very individualized kinds of training and booster training and support needed. But that's really important to do for, you know, really even a good year until you feel comfortable that that practice has really been embedded, adopted, and it's going to be sustained. So this is really the kind of the key piece once you go through all those steps to make sure that that good work is really going to take effect. You know, it is reimbursable. I don't want to spend a lot of time on this because it's going to be different depending on the setting. So, you know, it's important, obviously, as part of the planning process to figure out how do you get paid for this within your particular system. These are the different codes. So just overall lessons learned, committed leadership, talked a lot about that, the culture supportive of addiction, getting that team together right from the beginning of all the key players so you have that broad buy-in, making sure workflow, that you spend that good time being that investigative reporter, doing that good flow chart, and then figuring out the best way for that particular practice. We can put a protocol together that works, that integrates into the flow and is customized. Training alone, we've talked about that, doesn't institutionalize. Be data-driven, as we talked about, to track effectiveness. Be flexible. You know, the first protocol you do may not work. The data may show that it's not the folks that are doing it wrong, it's we just didn't design it right. Maybe we need to fix something. So be flexible. You may need to change along the way. Get it into the EHR, that's going to be critical. And then that follow-up and monitoring, as we talked about after the training, and then make sure that you guys are there, not just as the referral source, but real partners in this whole process. Okay. I think we're both open for questions. Thank you.
At what age should you start?
Kids,
Yeah, like at what age should you start?
12 and over.
12 and over.
Six, I guess, for Thursdays.
Of all the elements of implementation, what do you think is the one that's the most challenging?
I would say getting the providers to consistently do the brief interventions appropriately. I think once they get it down and are on a roll, they do it, but getting them to, really consistently do it and do it the right way based on the score. They might mention it, but they might not refer the right patients who need to be referred. So they might, or they may not even have the conversation around helping the patient think about a possible referral. So I'd say that, and then the electronic health records are challenging because you need to customize systems. So it can be challenging, and it can be, time consuming to actually have to make those modifications.
Outcome data. So you get providers to do this, and is there a follow-up that says this is the improvement that was noted, or this was the impact that this had, or?
We track referrals to treatment, and in our hospital SBIRT studies, we actually track whether the patients go to treatment. In those systems where, we have the actual on-site in-system substance abuse treatment, we can see whether patients go to treatment. In the other systems where we're just making referrals because we haven't implemented the consents to be able to have that communication, we haven't been able to track that. But we haven't done this under a research study, so we haven't really tracked, reductions in use, particularly for programs.
With the added use of technology, and you're doing brief intervention, so referral to treatment, there's a lot of barriers still with insurance and length of time and working and everything else. And technology, you can have your interview, you can have sessions over the computer or more convenient to a patient's home, and they can get that treatment. Is that being utilized, or?
I think that's certainly the direction some people are going. The Yale group has just computerized the cognitive behavioral therapy sessions now, where you can actually be doing that, some of that by computer. So I think particularly in places where I think it's difficult to have that coordination happen. Is anyone here from Virginia? Oh, but the recording is going. I think it's very I think there are a lot of things in Maryland where those linkages can happen more expeditiously because there's kind of treatment on demand here, more so than when you start to get to something, and relatively speaking, at least, where I think in some places in Virginia, it's really hard to get that link to be improved, so there's a long lag time till they first get into treatment, et cetera. So I think we've been trying to look for things we can do during that interim period. If that's not fixable in the current system, then can we offer things like potentially a computer intervention or something that would help until they actually can get that first appointment and get into treatment, sort of.
So they're not comparable. The live intervention is still better than the computer. It's not, they're not like almost handy.
Well, so there, if you think about that kind of continuum of people with addiction across the continuum, the brief what the statistics, at least for alcohol, show is that the brief intervention by itself, without the referral for treatment, can be an intervention in and of itself. So I think for a segment of that group, that's the whole focus of it. And so for example, when we've done the computer-based intervention, a lot of the work we've done has been with postpartum women in Detroit, and we then track them and get not just self-report, but actually hair analysis to really look at their drug use. That looks like it works about the same as a live person delivering that sort of a brief intervention. Now, whether that's better than what you get if they actually went into formal treatment, I don't know, but for many of them, they weren't interested in going into formal treatment.
Right, yeah, there's a lot of barriers.
It's the alternative. So I think it really is important to recognize that it isn't sort of one size fits all, and that one of the things that's attractive about SBIRT is that it really can serve as treatment for a subset of individuals.
And the other thing, I guess, part of it, we focus so much on, does the person decrease their use, does the person decrease the use? And as you're saying, a lot of times patients are, really not ready, and they're not, and so you can't just make, what primary care providers do right now is they just make the referral, and patients never go because they're not ready to go. So spending the time really working with them to figure out, what is it going to take to get them perhaps ready to go at some point. I mean, that might take a really long time too. And the fact that, we can have these conversations, we begin to have these conversations, and we're bringing these patients back, because we are bringing them back because they're primary care patients. And that's where I feel like even if they're not doing it perfectly, these providers, the fact that they are now having the conversations and continuing to have the conversations where they never were having them before, ultimately is going to make a difference with patients in thinking about their use. I mean, it's better than not talking at all about it.
Absolutely. Yeah, I really like that about the doing it at every visit, normalizing it, because you're not going to bring somebody from a pre-contemplation stage to going to treatment that same visit. It's just not going to happen. So
And that's what we expect right now. We have a heroin user, primary care provider. They either write them off, they're never going to go, so I'm never going to talk about it, or just send them to the social worker, let them make the referral, and they're never going because they're not ready to go. Any other thoughts? Think it's doable? Yeah?
I have a question for you, actually. So based on your experience with those, that was really fascinating to listen to. What are your thoughts about the agencies where there isn't that leadership, and that they're the ones that we're probably kind of all saying? Any thoughts about sort of next steps with that, or do you think that is going to change, and if so, how?
Yeah, I mean, if there's total resistance, there's, I think what we tried to do was focus on early adopters, so, and then sort of put peer pressure on. So I think that's always a good strategy. So if you can get, when you're starting out, a couple of wins and champions, and they do the talking, and you get them talking to each other. So, if they're not bought in, say, well, why don't you talk to the medical director over here and see how it works for them. You talk to the CEO over there and check out, what you think. And, we had that with the hospital that we're going to Mercy, a second hospital. And, they were bought in conceptually to the idea, but they were, a little worried, how's this all going to work? And is this really right? And it's going to take more time, layered on. And, we spent a good 3 months really having some real good partner relationships with the first hospital. We took Mercy over to the ED at Bon Secours. The medical staff all talked. They checked us out. How are these consultants that are working with us? How's that all going to work? And so, we really had a lot of share time, and ultimately they were like, yeah, we want to do this.
I didn't get to hear the morning presentation. Did Tom McClellan talk a little bit about his experience with starting to do screening at their health system?
I didn't hear it either, but I don't think he did he?
Okay, Sam? So I know at a previous presentation, he was talking about trying to start to do some of this within one of the healthcare systems.
At Penn?
Yeah.
Oh, I've heard him do that.
Yeah, and talking about one of the things he learned in first talking to a bunch of the department chairs and thinking about really how to just start to make this part of the electronic record, and then work on the brief intervention, that ultimately when he started to kind of take that down to more specialized subgroups, when he met to present the data, I think it was about breast cancer and alcohol, after he finished, they asked him for information about what he presented, and then they read it over and sort of made the determination, oh, this looks like it might be good, and kind of came back to him. And then that at the time what he said was, what he learned was he would have gotten someone within their group to be the advocate to begin with. And that it didn't matter how forthcoming he was and how kind of user-friendly he tried to make that, and Tom's one of the most user-friendly people I know, that it was different when it came from somebody within their group. And so I think that really is important to be thinking about how to implement that.
I can't emphasize too that the business case is really important.
Well, that's what I was thinking, because some of this might change for other reasons.
So, and we did make the business case, right from the beginning.
At the VA, we have the right on our front page. It has that you need to do your audit C or your alcohol screen, depression screen, and that's seen by everybody. So I'm a behavioral health nurse, whereas the primary care sees, everybody sees it, the same assessment comes up, and then once the number gets flagged, they automatically get referred. The system refers them right to and then the social worker only has 5 days before they have to answer to it, and then they have to
That's
follow up
right.
every week after.
Yeah, we're implementing that at Mercy, where it's gonna be an automatic
Automatic, yeah,
referral to a
relays.
peer recovery coach to do the PI.
That way it doesn't matter, you know, if
Yeah.
I see it, you see it,
Yeah.
he sees it, whoever says it,
Yeah.
Right,
you know,
the-
primary care
See, I think
asks,
that's-
we ask, everybody asks.
I think that's
Right.
great, because really it builds that team sort of approach that you're talking
Yeah,
about.
and
sort
it-
of,
and it's
that's
not-
everybody's sort of responsibility.
Right, it's not singling out one group of people, like, oh, you have to do this, you know, because now everybody's asking, and they're just like, no, yes, no, you know, like, they're just so used to it now.
Yeah, yeah, really, I think this is about making it normative kind of stuff.
You know, you just gave me an idea. I think probation need, remember we were talking
Yes.
earlier. I think this is something that probation
They do.
could start, you know, have some people in there. So, because, you know, somebody come in, you know, I was a probation officer, you have one positive drug test, take him back to court and just lock him up for 5 years. You know what I mean? And I'm gonna take this back, because I think this is not a conversation that is in probation.
Right.
You know,
Yes,
not
it
at
should
all.
certainly be in probation.
You said the VA, and that thought popped in my head. It was
Yeah.
like,
Oh, gosh,
this
I-
conversation.
There's actually good research on it. Terry Moore
Yeah.
has done a ton of research.
Yeah.
And pay tax deductions and stuff.
Yeah,
Yeah,
I
also
think
that
this is,
too.
yeah, I
Yeah.
think I'll do some more research. I think this is a good idea to
Yeah.
start the conversation.
Absolutely.
Thank you.
Okay, thank you, guys.
Thank you.